Welcome to the module on multiple myeloma. My name is Tim Peterson. I am a clinical pharmacy specialist at Memorial Sloan Kettering Cancer Center in New York, New York. This presentation is part of the ASHP, ACCP, BCOP Pharmacy Specialty Review course. This is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. The activity is designed to be interactive with questions posed to you at several points. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answer and the correct response in your handout. The disclosures for this presentation are listed below. The learning objectives for this presentation are listed below. Please note that spinal cord compression is covered only in the handout. The REMS, or risk evaluation and mitigation strategies, will be discussed primarily in the handout, but there we're thinking about the immunomodulatory agents, Lenalidomide, Lenalidomide, and Pomalidomide that have that potential for severe teratogenicity. So not only do they need to go through a specialty pharmacy and a REMS requirement, but it's an important piece that clinical pharmacists can be involved in with regard to education of not just patients, but providers, and then insurance of compliance with the REMS requirements. We also have a new REMS program for belantamab mafodotin, which was just FDA approved. Owing to its unique ocular toxicity, we'll talk a little bit about the REMS program for that in the presentation here. Listed on this slide for your reference is our lecture outline and how we'll discuss multiple myeloma before proceeding to the supportive care considerations for myeloma patients. Before we get started with our discussion, we'll start with an audience response question. Here we have JM, who's a 54-year-old male with newly diagnosed monoclonal gammopathy of undetermined significance, or MGUS. His baseline labs include a serum creatinine of 0.8, calcium of 8.6, hemoglobin of 12.5. According to the NCCN clinical practice guidelines in oncology, which of the following would be the most appropriate for JM at this time? The correct answer here is D, observation. This patient was diagnosed with monoclonal gammopathy of undetermined significance, for which the current standard approach is observation. Typically, patients will be observed every 6 to 12 months depending on provider preference. First three options are reasonable approaches for primary induction therapy. Lenalidomide and Dexamethasone is an appropriate doublet therapy for a patient who is not deemed to be transplant eligible, potentially due to their age or significant comorbidities. Similarly, VMP is an appropriate option for a non-transplant patient as well. VRd is a reasonable triplet approach for patients who are either transplant eligible or non-transplant eligible. However, all three of these should be reserved for patients with active multiple myeloma and not a patient with MGUS who should be observed. We're not going to spend much time talking about the diagnosis and workup of multiple myeloma, but I do think it's important to touch on the myeloma-defining events, which make up the CRAB criteria. I think many people are already familiar with the CRAB criteria from prior experiences with myeloma patients or prior rotations. But looking through these, the first sequelae is calcium. This is hypercalcemia, which is largely due to the bone involvement that can happen with multiple myeloma. What you see is these terminally differentiated plasma cells can secrete interleukins, which cause upregulation and activation of osteoclastic activity, subsequently increasing bone resorption, causing release of calcium from the bone into the plasma, and subsequently hypercalcemia. We can also see renal dysfunction. This is due to a couple of things. One, when you think of myeloma kidney, technically we're thinking of those light chains, which can be secreted by plasma cells. The light chains like to deposit in the kidneys and other end organs, but primarily the kidneys. This is called light chain cast nephropathy, which can lead to the renal dysfunction that oftentimes patients present with when newly diagnosed with multiple myeloma. You can also see hypercalcemia contributing to renal dysfunction. It's a bit of a vicious circle. So hypercalcemia can cause a contraction dehydration, which further reduces renal function. Anemia can be due to multiple things. Probably the most common would be the plasma cells that are in the bone marrow can actually physically pack out the bone marrow. This reduces the cellularity of the bone marrow, and it can hinder the other lineages and the ability for a normal hematopoietic process to proceed, subsequently decreasing the red blood cells. It can decrease the platelets, as well as the white blood cells on occasion. We can also see anemia due more so to chronic kidney disease. The chronic kidney disease that can be associated with multiple myeloma, as above, can cause reduction in the activity of erythropoietin, which can further exacerbate the anemia associated with the disease. Lastly, we have the bone involvement itself of multiple myeloma. Here, I already mentioned that we have upregulation and activation of osteoclastic activity. This can cause weakening of the bones. This leads to fractures, lytic lesions. It can cause spinal cord compression. These things upon presentation and new diagnosis of multiple myeloma can be quite debilitating. So these are very important things to keep in mind for the myeloma-defining events for patients newly diagnosed. This slide is primarily for your reference. I would like to reiterate, though, that the management of MGUS or monoclonal gammopathy is observation, typically every 6 or 12 months depending on the provider. Similarly, the management of smoldering multiple myeloma is currently observation or enrollment in a clinical trial. Enrollment in a clinical trial may be considered if a patient is deemed to be at high risk of progression to active multiple myeloma. This is primarily done utilizing risk stratification schemas, including the two most common, which are Mayo Clinic and the Spanish PETHEMA criteria. It's possible that in the coming years, these patients may be treated as active multiple myeloma. However, as of right now, the standard of care is observation. For active multiple myeloma, I just want to point out on the bottom right, the SLIM criteria. Independent of myeloma-defining events as per CRAB, patients may qualify for active multiple myeloma based on any of these criteria, including bone marrow plasma cells greater than 60%, free light chain ratio greater than 100, or greater than 1 focal marrow lesion on MRI. This is the last slide that's primarily just for your reference and for your information to refer back to. The primary staging systems that we'll see are the International Staging System, or ISS, and the Revised ISS, as are shown here. Historically, you may hear about the Dury-Salmon criteria, or Dury-Salmon staging. This is not really used much in clinical practice now, but you may see it in patients' charts who have been treated for years. The main difference between the RISS and the ISS is that the revised staging system incorporates, in addition to the beta-2 microglobulin and albumin, LDH and high-risk cytogenetic abnormalities. So you can see of the high-risk cytogenetic abnormalities that are listed in that table on the top right, the 3 on the left being deletion 17p, translocation 414, and translocation 1416 are the high-risk cytogenetic abnormalities that are incorporated in the RISS staging. Before we continue on to our primary treatment of multiple myeloma, we'll have our second audience response question. AS is a 62-year-old female with newly diagnosed multiple myeloma. Her corrected calcium is 11.4. She has 40% plasma cells on her bone marrow pathology, revised ISS stage 3 due to a beta-2 microglobulin of 7.5, and high-risk cytogenetics including deletion 17p and translocation 414, and she has a serum creatinine of 0.85. Her ECOG performance status is 0. She is eligible for an autologous stem cell transplant, and she expressed interest in receiving induction therapy with a monoclonal antibody. Which of the following is the most appropriate first-line treatment option? The correct answer is C, Daratumumab plus VTd, or Bortezomib, Lenalidomide, and Dexamethasone. This is based on the CASSIOPEIA trial, in which patients received 4 pre-transplant cycles of Daratumumab plus VTd, underwent an autologous stem cell transplant, and then received 2 consolidative cycles of Daratumumab VTd. A is incorrect because although Daratumumab, Lenalidomide, and Dexamethasone may be an appropriate frontline option, it should be reserved for non-transplant eligible patients as per the MAIA trial. B is incorrect because, again, although Elotuzumab, Pomalidomide, and Dexamethasone is a reasonable triplet therapy, this should be reserved for the salvage and relapse setting based on the ELOQUENT 3 study. In fact, Elotuzumab and Pomalidomide are not used in the frontline in any context. D is incorrect because Isatuximab, Pomalidomide, and Dexamethasone, while an appropriate triplet regimen, should again be reserved for the relapse setting based on its context used in the Icaria MM study. Looking at the treatment paradigm itself for multiple myeloma, we know that this is an incurable malignancy, unlike some other types of malignancies where patients may receive high doses of conventional chemotherapy and then be monitored thereafter for recurrence. And because of that, patients can really go on to numerous lines of therapy. Thankfully, we have several novel agents in the past couple of years. We're likely going to see an FDA approval very shortly of CAR T cells in multiple myeloma. We're learning about optimizing different combinations of medications, and we're learning more about the sequencing of therapies. We're seeing more and more upfront use of monoclonal antibodies. We have several regimens in which we can use Daratumumab in the front line, either in a quadruplet or a triplet therapy. either in the context of transplant eligible or non-transplant eligible patients. So we're learning more about how to optimally give these different combinations and how to sequence them either in the front line or giving a CD38 targeted agent before or after a SLAM-F7 targeting monoclonal antibody, for instance. And when we look at the treatment paradigm, our initial induction therapy followed by consolidative therapy, the question now comes up, do we transplant patients immediately or can we do a delayed transplant where we collect stem cells for someone who's transplant eligible, but then we see the depth of their response. We're looking at new surrogate markers. We're looking at minimal residual disease or MRD negativity to help potentially guide therapy. It's something that's not totally ready for the limelight yet, but we're starting to see more of MRD negativity and the depth of response being a surrogate marker for progression-free and overall survival. So many providers may use the depth of response to potentially delay transplant for their first relapse. You may collect stem cells for patients that are transplant eligible and then just hold on to them. Maybe patients go directly onto a lenalidomide maintenance type strategy, and then at first recurrence, you can give those stem cells in an autologous stem cell transplant. So that's something that's definitely potentially shifting, and it's a dynamic paradigm right now. We also have numerous agents that are available for maintenance therapy, including lenalidomide, Bortezomib, and Ixazomib right now. You'll see some other of the newer agents being used in maintenance strategies, but currently the only recommended agents are those three in the maintenance context. Although recent discussion is focused on immediate versus delayed transplant, it's still very important to have that determination up front regarding transplant eligibility for newly diagnosed myeloma patients. Transplant eligibility no longer is based primarily on age. Rather, the shift in focus has been towards performance status, whether or not patients have significant comorbidities that may affect their ability to tolerate primary induction therapy and consolidative therapy with autologous stem cell transplant. Whether you have a patient who is transplant or non-transplant eligible, 3-drug regimens are preferred over doublet therapies. And we're starting to see more and more quadruplet therapies incorporating Daratumumab in combination with standard triplets. There's no preference as of now being given to those quadruplet therapies over triplet therapies. Rather, there's only a preference for triplet or quadruplet over doublet therapies, if possible. If a patient's deemed to be a transplant candidate, it's recommended to collect stem cells after 3 to 4 cycles. The reason for this is stem cell yield of CD34 positive cells can be reduced in patients that have prolonged exposure primarily to lenalidomide-based regimens. So regardless if you're planning on an immediate or delayed transplant at first relapse, it's recommended to collect stem cells within 3 to 4 cycles of initiating induction therapy. Here we have our introduction to the primary induction therapies for transplant-eligible patients, and I'll just point out a couple of things on this slide. The first being the only Category 1 recommendation we have in this context is VRd, or Bortezomib, Lenalidomide, and Dexamethasone triplet. This should largely be the textbook answer and gold standard for primary triplet therapy, as this will be the standard of care for most institutions in the frontline setting. Bortezomib, cyclophosphamide, and dexamethasone, or CyBOR-D, this is going to be preferred in patients that present with renal insufficiency. It's a lot easier to administer these 3 drugs in patients with labile renal function compared to a primary triplet therapy that may include lenalidomide. Lenalidomide, as you may know, is cleared renally, and it can be very difficult to dose it appropriately while minimizing toxicities in patients that have a labile renal function. So CyBOR-D will be preferred both in transplant-eligible and in ineligible patients that have renal dysfunction at presentation. The other entity under the plasma cell dyscrasia umbrella in which this may be preferred is in the context of light chain amyloidosis, when you have deposition of light chains into end organs. This can be end organs including the GI tract, cardiac amyloidosis, renal amyloidosis, that causes symptomatology that is in association with those end organs that are targeted. So patients with amyloidosis may receive CyBOR-D, or actually recently, based on some recent trial data, the Andromeda study, Daratumumab in combination with CyBOR-D is a reasonable approach for these patients as well. Looking at other recommended regimens, we have KRd, or Carfilzomib, Lenalidomide, and Dexamethasone is going to be the last primary triplet therapy that you're going to see in this context. This is preferred for some providers because it's been shown that Carfilzomib, being a second-generation proteasome inhibitor, it has more potent proteasome inhibitory effect when compared to Bortezomib. So the thought is that maybe it has more anti-myeloma effect. And it has been shown that carfilzomib can cause deeper responses. So we're talking about MRD negativity that I mentioned on the previous slide. We know that MRD negativity may be an appropriate surrogate marker for progression-free survival and potentially overall survival, but the jury's still kind of out on whether or not MRD negativity can drive your therapeutic decisions right now. We'll discuss a head-to-head study momentarily that actually looked at VRd versus KRd. It's called the Endurance trial, and it compared these two primary triplet therapies to see if one may be preferred over the other. The next regimen that we have here is Daratumumab in combination with VRd. This is based on the GRIFFIN study. Now, the GRIFFIN study looked specifically at patients who were transplant eligible, and they gave them 4 pre-transplant cycles of Daratumumab in combination with VRd. They were transplanted, and then they got 2 consolidative cycles of Dara-VRd. So this is an appropriate, reasonable option for transplant-eligible patients. And then lastly, we have Ixazomib, Lenalidomide, and Dexamethasone. This one is going to be preferred in patients that maybe they need an all-oral regimen. They have difficulty coming into clinic. There are other concerns with regard to them coming back and forth, particularly in the past year, we had a lot of patients that we switched over to Ixazomib-based therapies compared to other proteasome inhibitor-based therapies for preventing them from coming in and out of the clinic in the context of the ongoing pandemic. So there certainly are benefits to this regimen as well. This slide outlines the remaining therapeutic options we have for transplant-eligible patients in the front line. There are just a couple of things that I'd like to point out here. The first is that we have 2 additional Daratumumab-containing therapies that are available to us. On the bottom right, you can see Daratumumab in combination with VTd, which is Bortezomib, Lenalidomide, and Dexamethasone, as per the CASSIOPEIA trial. We have Daratumumab in combination with Cybord-D, or cyclophosphamide, Bortezomib, and Dexamethasone, as per the LYRA trial. The LYRA trial, which we'll talk about momentarily, actually included both newly diagnosed and relapsed refractory patients with multiple myeloma. One additional thing I want to point out when we're talking about the Daratumumab-containing regimens, we now have 3 that are possible in the transplant-eligible patient, but we also had FDA approval recently of the subcutaneous formulation of Daratumumab. Daratumumab formulated in combination with hyaluronidase, allowing for subcutaneous administration of Daratumumab. We'll talk briefly about the Columba trial, which led to that approval, but it should be noted that even after FDA approval, the NCCN guidelines were immediately updated, and they basically said that any Daratumumab-containing regimen that is recommended by the NCCN can use the subcutaneous formulation of Daratumumab in lieu of Daratumumab intravenous formulation. So that will hold for all of our Daratumumab-containing regimens that we'll discuss. The first landmark trial we'll look at is the SWOG study by Dr. Dury. This study is basically the basis of primary triplet therapy with VRd being preferred over doublet therapy. You can see that we had 525 patients who were newly diagnosed that were randomized to lenalidomide and dexamethasone with or without bortezomib. Bortezomib, I'll point out, was administered intravenously and it was given biweekly on days 1, 4, 8, and 11. There have been multiple modifications to the administration, both route and schedule for Bortezomib that we'll talk about momentarily. These patients were originally deemed to be non-transplant eligible. However, this study basically serves as the primary article that supports VRd triplet therapy in both transplant eligible and ineligible patients. Lenalidomide given in combination with just dexamethasone was given as 25 milligrams through days 1 through 21 out of 28. However, when it was given with Bortezomib as part of VRd, given the biweekly administration of Bortezomib, the lenalidomide was given 25 milligrams days 1 through 14, with 7 days off in a 21-day cycle. If we look at the responses, you can see clearly the overall response rate was higher at 82% versus 72%, with deeper responses occurring, higher frequency of CR in the triplet therapy. Median progression-free survival and median overall survival were both statistically significantly improved, and this thus is what led to, again, triplet therapy being preferred for anyone that can tolerate it over doublet therapy. If we look at the toxicity profile, if you don't work with multiple myeloma patients and you're thinking primarily in BCOP context, you should always be associating Bortezomib with peripheral neuropathy and how we can mitigate that risk. The potential for peripheral neuropathy with Bortezomib can cause dose delays, it can cause reduction in dose intensity, and it can even cause discontinuation because that neuropathy can be profound. The next study is the basis of transplanting patients following primary induction therapy with standard triplets. You can see this is a large study that randomized 700 patients to primary induction therapy with VRd. They underwent stem cell collection, and then they were randomized to melphalan-based autologous stem cell transplant or additional VRd. Both arms then underwent lenalidomide maintenance thereafter. The results here clearly show the benefit of transplant in addition to VRd triplet therapy. You can see significant improvement in the median progression-free survival, higher rates of CR with deeper responses, and additionally higher rates of MRD negativity with 79% of patients versus 65% of patients attaining MRD negativity following transplant in addition to VRd. This study is one of the bases for MRD negativity being used and proposed as a surrogate marker. In a subgroup analysis of this study, they looked at patients who attained MRD negativity compared to those who did not attain MRD negativity. They found that those patients who were able to get to MRD negativity, regardless of whether they received VRd or VRd with transplant, had a greater progression-free survival than those patients who are MRD positive. Thus, there is potential that regardless of how you attain MRD negativity, you may have the potential to have greater progression-free survival. The next few slides will be looking at the clinical trials that led to daratumumab-containing regimens being incorporated in the transplant-eligible patient population. The first study is the CASSIOPEIA study, which looked at daratumumab in combination with VTd, or Bortezomib, Lenalidomide, and Dexamethasone. You can see in this large randomized open-label trial, patients received 4 cycles of VTd plus or minus daratumumab pre-transplant. They underwent an autologous stem cell transplant and then subsequently received 2 consolidative cycles of VTd plus or minus daratumumab. The novel primary endpoint for this and other daratumumab-containing studies recently is stringent CR at day 100 post-transplant. You see that this was significantly improved with daratumumab. This is an important time point post-transplant because at about day 100 is the time point where we have disease assessment for the oncologist to make the decision whether a patient can proceed to a maintenance strategy with, say, lenalidomide, or if they require additional consolidative treatment, continuation potentially of their primary induction therapy, or if they're progressing, maybe they need salvage therapy already. Secondary endpoints for the study looked primarily at the depth of response, again, focusing on MRD negativity with 64% of patients receiving daratumumab attaining MRD negativity compared to 44% of those without daratumumab. The GRIFFIN study looked at daratumumab in combination with standard VRd triplet therapy, or Bortezomib, Lenalidomide, and Dexamethasone. The layout for this study was the same as CASSIOPEIA with 4 pre-transplant and 2 post-transplant cycles. Patients then proceed to lenalidomide plus or minus daratumumab maintenance therapy thereafter. The primary endpoint was similar to CASSIOPEIA with stringent CR at day 100 post-transplant. 42% of patients receiving daratumumab compared to 32% of patients receiving just triplet therapy attained stringent CR at day 100. Secondary endpoints again looked at depth of response, including stringent CR after longer follow-up, where you did see deepening of responses with daratumumab and VRd, as you would expect with ongoing therapy, and rates of MRD negativity of 51% with daratumumab compared to 21% with just VRd. The adverse effect profile, as you may expect with the addition of daratumumab, included increased myelosuppression and higher rates of upper respiratory infections. The final transplant-eligible daratumumab-containing regimen we'll look at is daratumumab in combination with CyBorD, as per the LYRA study. The LYRA study uniquely incorporated both newly diagnosed and relapsed myeloma patients in this non-randomized, single-arm, open-label study. Patients received bortezomib subcutaneously on a weekly basis for 3 weeks and 1 week off, and cyclophosphamide at a dose of 300 milligrams per meter squared orally on a weekly basis. Eligible patients were allowed to undergo transplant, and all patients then proceeded to daratumumab in combination with dexamethasone maintenance therapy. You can see in this table the overall efficacy outcomes, including an overall response rate of 81 and 71% respectively in newly diagnosed and relapsed patients, with deep responses greater than VGPR in 56 and 64% of patients respectively, and progression-free survival at 12 months of 87% in newly diagnosed and 66% in relapsed patients. This study serves as the basis for the NCCN guidelines incorporating daratumumab in combination with CyBorD for newly diagnosed transplant-eligible and ineligible patients, as well as in the setting of salvage therapy for relapsed multiple myeloma. As was briefly mentioned, Daratumumab in combination with hyaluronidase as a subcutaneous formulation was FDA approved in May of 2020. The NCCN guidelines were then immediately updated to include the subcutaneous formulation as a suitable substitute for IV Daratumumab as part of any NCCN recommended regimen. This is administered as a flat dose of 1,800 milligrams Daratumumab in combination with 30,000 units of hyaluronidase, which allows for a higher volume to be administered due to increasing permeability of the subcutaneous layer. Hyaluronidase is the same coformulant that's used for rituximab and trastuzumab as part of prior monoclonal antibody subcutaneous formulations. Local and systemic injection-related reactions may occur. Systemic injection-related reactions occur less frequently with the subcutaneous formulation than they do with the intravenous formulation, although pre-medications are still required. Systemic reactions occurred in the clinical trial Columba at a median onset of 3.7 hours. Institution practice will vary between institutions. However, many institutions have adapted a monitoring period that may account for this median onset post-first injection.
For our next audience response question, we have AS, who is a pianist and concerned about peripheral neuropathy. Following a discussion of potential options for induction therapy, AS inquires which of the following Bortezomib-based regimens is least likely to cause peripheral neuropathy.
The correct answer is C, 1.3 milligrams per meter squared subcutaneously given biweekly. Answers A, B, and D are all administered intravenously, which has exhibited increased risk of peripheral neuropathy compared to subcutaneous administration. Patients who receive weekly Bortezomib compared to biweekly Bortezomib actually experience similar incidence of peripheral neuropathy. However, those patients who receive weekly dosing may have fewer dose reductions and actually have higher dose intensity of Bortezomib per cycle. Peripheral neuropathy is an important toxicity to keep in mind when dosing Bortezomib for multiple myeloma patients. It's a toxicity that may lead to treatment delays, discontinuation of therapy, or reduction in the dose intensity of Bortezomib. Bortezomib was originally studied in clinical trials as 1.3 milligram per meter squared given intravenously biweekly on days 1, 4, 8, and 11. Modifications have subsequently been made to both the schedule of administration of Bortezomib and the route.
Delving into some of the literature that supports these modifications of Bortezomib-based regimens, we first have the Reader study. This looked at two cohorts, the first being biweekly standard administration of Bortezomib 1.3 milligram per meter squared intravenously on days 1, 4, 8, and 11, as you may expect. And the second cohort is patients receiving weekly Bortezomib at 1.5 milligram per meter squared intravenously on days 1, 8, 15, and 22. You can see on the right side that the response rates were similar depth of response as well, with CR and VGPR rates being similar between the two arms. However, dose reductions were significantly higher in the biweekly compared to the weekly group. It was noted that patients receiving weekly administration at 1.5 milligram per meter squared actually had a higher overall dose intensity of Bortezomib throughout their cycles. Interestingly, peripheral neuropathy rates were actually similar between the two arms. However, overall grade 3 and grade 4 toxicities were higher in the biweekly compared to weekly dosing administrations. Utilizing this data from this study, oftentimes Bortezomib will be given on a weekly basis in clinical practice to improve the tolerance. However, it should still be noted that biweekly administration on days 1, 4, 8, and 11 is very much so still the standard of care in clinical practice. It should also be thought of as the standard of care when looking at comparator arms for clinical trials. If we're trying to compare something to a current standard therapy such as VRd, you should largely be thinking of that as biweekly dosing on days 1, 4, 8, and 11. The next modification to Bortezomib administration is looking at subcutaneous administration in lieu of intravenous in patients with relapsed myeloma. In this study, they utilized standard 1.3 milligram per meter squared on a biweekly basis and randomized patients to subcutaneous or intravenous administration. You can see that after 4 cycles, the overall response rate was exactly the same between arms, with similar 1-year overall survival. Adverse events above grade 3 were significantly higher in the intravenous compared to subcutaneous arms, and most notably to us when we're thinking about Bortezomib, all grade peripheral neuropathy was significantly higher with intravenous compared to subcutaneous administration, and importantly, grade 3 and above peripheral neuropathy was 16% versus 6% with intravenous versus subcutaneous administration. This is very important because grade 3 peripheral neuropathy is actually very significant toxicity. And this is where we're starting to see interference with patients' activities of daily living. So this is something that has a very significant effect on patients' quality of life. So when we're looking at bortezomib administration, we should be giving subcutaneous administration, and intravenous administration has fallen to the wayside. To briefly review some of the National Comprehensive Cancer Network recommendations for non-transplant eligible patients, we have the recommendations here. So category 1, largely you're still going to be seeing VRd, our standard triplet therapy. You can see modification to VRd, which would be VRd light or RVd light, and this is somewhat attuned to giving mini-CHOP in a non-Hodgkin lymphoma patient to improve tolerance. You can also see doublet therapies. This is really the only context in which we'll see doublet therapy. You can either see bortezomib in combination with dexamethasone, or much more frequently you see lenalidomide in combination with dexamethasone. Again, this is another category 1 recommendation. And something in the last couple of years based on the MAIA trial is daratumumab in combination with lenalidomide and dexamethasone. We're seeing a lot of this being utilized in clinical practice because it is a mild therapy, but it's also very active and has very potent myeloma effect. So this new triplet therapy is something that can be considered for non-transplant eligible patients. Again, similar to transplant-eligible patients with renal dysfunction, Cy/Bor-D, bortezomib, cyclophosphamide, and dexamethasone would be your standard of care for patients who present with labile renal function. If they show a response to initial induction therapy with Cy/Bor-D and their renal function improves, you can then consider transitioning them over to a standard triplet therapy. Additional recommended regimens include daratumumab in combination with bortezomib, melphalan, and prednisone, or Dara-VMP. This is based on the All-Sion trial. This regimen is largely not going to be seen very frequently in the United States because VMP in and of itself is more of a European-based regimen. We have a lot of different agents that we can utilize in the United States, and VMP has largely fallen out of favor. The next one that we also saw in the transplant-eligible patients based on the LYRA study is daratumumab in combination with Cy/Bor-D. In this study, they looked at patients who were transplant-eligible, non-transplant eligible, and with relapsed and refractory disease. So this is actually recommended by the guidelines in all of those contexts. Finally, our last standard triplet therapy that we see in transplant-eligible and ineligible patients would be KRd, Carfilzomib, in combination with lenalidomide and dexamethasone. Again, some practitioners may use this to try to deepen their responses, knowing that the second-generation proteasome inhibitor may have more potent effect. However, we'll talk momentarily about KRd as opposed to VRd in primary induction therapies. The triplet of KRd, Carfilzomib, lenalidomide, and dexamethasone in newly diagnosed myeloma patients has primarily been studied in phase 1 and phase 2 small trials. The first one here, studied and published in Blood in 2012, actually, looked at a small number of patients with newly diagnosed myeloma who received KRd for 8 standard cycles, followed by a maintenance schedule of KRd thereafter. You can see 62% of patients attained at least a near complete response, with progression-free survival at 24 months being 92%. Notably, adverse events, the venous thromboembolism rate was 17%, which is a little bit higher than you would typically expect utilizing immunomodulatory agents with standard or low-dose dexamethasone. Neutropenia, 17%, and the neuropathy was actually noted to be 23%. However, Carfilzomib we don't tend to think about being a large culprit for causing peripheral neuropathy, particularly when we think about it in the context of Carfilzomib versus Bortezomib. The second primary study that we have is Corday et al. From the National Institute of Health. Again, they looked at a very small group of patients with newly diagnosed myeloma, and they actually included a subset of patients with high-risk smoldering as well. For this, they again got 8 cycles of KRd, and then they had 24 cycles of lenalidomide maintenance thereafter. For this one in particular, they're looking at the depth of response, and in particular looking at MRD negative-based complete remissions, or complete responses, excuse me. They found this to occur in 62% of patients, with a median duration of response of nearly 66 months. Again, notably for the toxicity profile for this, the rate of venous thromboembolism for these patients was actually 24%. And this, in combination with the prior study in Blood, shows that there may be potential increase in thrombogenicity of Carfilzomib's contribution to an immunomodulatory agent with dexamethasone in the front line. The Endurance trial was a much anticipated phase 3 trial that finally looked at comparing VRd to KRd in the front line of multiple myeloma management. For this, they looked at patients who are ineligible for, or at least not intended for, immediate stem cell transplant, although patients did undergo transplant in 28% of the VRd patients and 27% of the KRd patients. And these were standard intermediate risk patients, which means that they excluded those with high risk cytogenetics and patients that had circulating plasma cells indicative of plasma cell leukemia. The VRd arm, as you may expect, was the standard textbook answer of Bortezomib administration, being a biweekly dosing for a 21-day cycle. KRd was administered at 36 milligram per meter squared on a twice-weekly dosing basis. There was no difference in the median progression-free survival or in the 3-year overall survival. However, there were deeper responses with KRd, 14% attaining at least a CR, and actually 74% compared to 65% attained at least a VGPR. As you may expect, Bortezomib had significantly higher rates of neuropathy, with grade 3 to 4 being 8%, compared to less than 1% with Carfilzomib, and they looked at a composite of cardiac, renal, and pulmonary toxicity. Grade 3 to 5, actually, of Carfilzomib was 16% compared to 5% with Bortezomib. So ultimately, we're looking at no significant difference in progression-free survival, but we need to note that this was just standard intermediate risk patients, so there's still a question that some folks are bringing up as to whether there is benefit of using the second-generation proteasome inhibitor for high-risk patients in the front line, and we don't have a good answer for that yet. We did, as expected, see a higher depth of response with Carfilzomib and KRd than VRd. And it really just brings back to the general focus of toxicity profiles should really play into the treatment selection, because we don't know that one of these regimens is necessarily superior. We know that neither is non-inferior, but owing into the toxicity profile for the unique agents can help to drive therapy decisions. The first trial was the basis for our primary doublet therapy in non-transplant eligible patients. This was a very large phase 3 study that looked at newly diagnosed patients who were not intended to proceed to transplant. There were 3 arms that looked at either lenalidomide and dexamethasone for a limited time course of 72 weeks, lenalidomide and dexamethasone until disease progression or continuous dosing, and then MPT, which is melphalan, prednisone, and thalidomide for 72 weeks. Looking at the responses, you can see the median progression-free survival was actually improved with lenalidomide and dexamethasone for continuous dosing until disease progression, compared to both lenalidomide and dexamethasone for a definitive 72-week course and MPT for a 72-week course as well. The overall survival at 4 years was also higher, with lenalidomide and dexamethasone continuously dosed at 59% when we look at it compared to our historical context and our historical comparator of melphalan, prednisone, and thalidomide. There were higher rates of grade 3 and 4 toxicities in the MPT compared to the lenalidomide and dex as a composite group, and there were fewer hematologic and neurologic events that occurred with lenalidomide and dexamethasone. The next 2 slides will discuss 2 of our transplant ineligible specific Daratumumab containing regimens. The first one is Daratumumab in combination with VMP, or Bortezomib, melphalan, and prednisone. This was a very large phase 3 study, again, looking at a primary endpoint of progression-free survival at 18 months. They found 72% progression-free survival in the Daratumumab containing arm versus 50% in the non-Daratumumab containing arm. Overall response rates were significantly improved with the addition of Daratumumab, as you would expect for patients who are treatment naive. And again, looking at depth of response, MRD negativity was 22% compared to 6%. This is a relatively mild therapy, so 22% MRD negativity in the front line is nothing necessarily to write home about when we compare to some of the other studies that we have available. But we also saw significant improvement in 36-month overall survival with the addition of Daratumumab to VMP. The hematologic toxicities were relatively similar between the 2 arms, but we did have more grade 3 infections, grade 3 and grade 4 infections with the addition of Daratumumab, which again you might expect when we think about the side effect profile of Daratumumab. We do expect infections. We expect upper respiratory infections and pneumonia in particular. Although this study led to FDA approval of this quadruplet therapy, I will say that it's not seen very frequently in clinical practice, again, owing to the fact that VMP is used relatively infrequently in the United States in general. The last Daratumumab containing regimen in the front line that we'll discuss is Daratumumab in combination with lenalidomide and dexamethasone. This was based on the MAIA study, which looked at lenalidomide and dexamethasone plus or minus Daratumumab. You can see that the overall response rate was significantly improved from 81 to 93%, and progression-free survival when originally published was significantly improved with the addition of daratumumab as well. Similarly, the MRD negativity rate, 24%, we just mentioned it was 22% with the all-Sion combination quadruplet therapy. So not a significantly high MRD negativity rate, but again, these are transplant ineligible patients, so we're looking to give them mild therapy that they can tolerate. Adverse effects, as you might expect, myelosuppression is significantly increased with the addition of daratumumab, as well as those infections, primarily owing to upper respiratory infections that we would expect. Based on the MAIA trial, this combination of daratumumab with lenalidomide and dexamethasone has become a favorite in clinical practice for folks. Oftentimes you'll see daratumumab with lenalidomide, dexamethasone, or lenalidomide and dexamethasone doublet therapy, or modification to VRd to VRd light for patients who are elderly with significant comorbidities and need something that they're able to improve the tolerance of their primary induction therapies. As we know, multiple myeloma is an incurable malignancy. Maintenance therapy is very much so a backbone of the treatment paradigm. Now, patients can be considered for maintenance therapy either following an autologous stem cell transplant or following an initial induction therapy. After initial induction therapy, the decision to go directly to maintenance therapy can be made for someone who was transplant eligible. If you've already collected stem cells and you've decided to do a delayed transplant, meaning that you hold on to those stem cells and you reserve an autologous stem cell transplant for their first relapse, or it could be considered for someone who was deemed originally to be transplant ineligible in the first place. Patients that are deemed to be transplant ineligible are going to benefit from a gentle strategy, such as a maintenance therapy after their initial induction therapy. And as of right now, we have 3 available agents that are recommended by the national guidelines. This includes lenalidomide, which is a category 1 recommendation for both transplant eligible and non-transplant eligible patients. Bortezomib, which can be used in either context, and then Ixazomib is actually a category 1 recommendation. Right now, it's only following autologous stem cell transplant, and that's based on one of the Tourmaline studies. However, there was a recent Tourmaline study that may make this an indication for non-transplant eligible patients as well, but knowing right now we just have Ixazomib as a category 1 recommendation following autologous stem cell transplant. Numerous studies looking at lenalidomide maintenance, either following transplant or in non-transplant eligible patients exist, but the primary study that people tend to refer back to is this CALGB study here. And this is following autologous stem cell transplant. At about day 100, patients were randomized to receive lenalidomide 10 milligrams daily versus placebo. This day 100 point, as I mentioned previously, is really where you're looking at disease assessment and deciding, do we go to a maintenance strategy after autologous stem cell transplant? Do we go with a little bit more intensified consolidative strategy to try to deepen the response, or do we need to move on to a salvage regimen that the patient has not been exposed to? The addition of lenalidomide over placebo improved the rates of progression and death at 34 months. You can see 37% in lenalidomide compared to 58% with placebo. Time to progression was also significantly higher with lenalidomide. But notably on the right, you can see the rates of secondary malignancies that occurred, both hematologic and solid tumor with lenalidomide following transplant, was higher compared to placebo. This is something that we always need to be considering in patients that we deem to be potentially at higher risk of secondary malignancies in the first place. Maybe lenalidomide-based maintenance therapy is not necessarily appropriate. These patients should also be screened for these secondary malignancies going forward, knowing that they may remain on lenalidomide maintenance for many years. 2 bortezomib-based maintenance therapy studies, just to touch briefly on, are the HOVON 65 and Upfront studies. In HOVON 65, they looked at patients following autologous stem cell transplant. They received an initial induction therapy with either vincristine, doxorubicin, and dexamethasone, which has largely fallen out of favor and it's not even in the guidelines any longer, or bortezomib, doxorubicin, and dexamethasone, which is a reasonable approach and still exists primarily in the guidelines in the relapse and refractory setting. They were randomized after transplant to either thalidomide-based maintenance daily or bortezomib every 2-week maintenance for 2 years. Progression-free survival was noted to be significantly higher by about 6 months with bortezomib-based maintenance. The Upfront study, on the other hand, was looking at patients who were randomized to either bortezomib-dex or bortezomib thalidomide dex or VMP, followed by bortezomib maintenance every week. Now you can imagine that giving it every week may have a higher potential to cause neuropathy as you have this cumulative exposure. So typically when you're using bortezomib maintenance, it's going to be more likely to be in an every 2-week setting compared to an every week. And one interesting thing that they noted with the upfront study is they actually saw a fair amount of patients that had responses that deepened with further exposure to bortezomib after their initial induction therapy. So this does show kind of a proof of concept that if you maintain them on this proteasome inhibitor-based maintenance therapy, you can still see deepening of responses after their primary induction therapy. The last maintenance study we'll look at is Tourmaline MM3, which is the basis for Ixazomib being a Category 1 recommendation as maintenance therapy following autologous stem cell transplant. In this randomized study, patients were randomized to Ixazomib or placebo maintenance, and you can see significant improvement in median progression-free survival. Importantly, there was no increase in secondary malignancies with Ixazomib maintenance therapy compared to placebo, which is important when we consider the alternatives, such as Lenalidomide, which can cause secondary malignancies. As I mentioned, Ixazomib is currently only recommended after autologous stem cell transplant. However, that may change going forward based on results of a recent publication in JCO, the Tourmaline MM4 study, also by Demopoulos et al. In this study, patients were randomized to Ixazomib maintenance versus placebo when they were non-transplant eligible following standard induction therapy. This may be something that's incorporated into the guidelines in the coming months. To summarize the primary treatment paradigm for frontline therapy in multiple myeloma, we do know that triplet drug therapy is preferred over doublet therapies when possible. However, it's getting more complicated now. We've had multiple introductions of Daratumumab into either quadruplet or triplet-based therapies. We don't know necessarily if those are going to be preferred over our primary triplet therapies being VRd or KRd. We do know that the addition of proteasome inhibitor to immunomodulatory agent and dexamethasone is improved over doublet therapy. Cyborg-D should always be preferred in patients with renal dysfunction, whether they are transplant eligible or ineligible, as well as patients with light chain amyloidosis. And like I said, monoclonal antibodies, although we don't necessarily know about the sequencing, and if we're kind of burning an option that would be in our back pocket for first and second relapse, by incorporating these Daratumumab-based regimens in the front line. This is still something that's being elucidated, but we do have several regimens that are recommended as options in both transplant eligible and ineligible patients in the front line. For our transplant candidate, we do want to collect stem cells after 3 to 4 cycles. That's to increase our CD34 yield to try to account for at least 2 to 3 autologous stem cell transplants. We can do primary maintenance therapy for transplant candidates or non-transplant candidates. Again, Ixazomib, as of right now, is a Category 1 only following transplant, but that may change soon given the results of the Tourmaline MM4 study looking at Ixazomib maintenance for non-transplant patients. Lenalidomide is a Category 1 recommendation for both transplant-eligible and ineligible patients. And Bortezomib is an option, again, that wouldn't increase the risk of secondary malignancies, although we do have that potential for cumulative exposure and potential increased risk of peripheral neuropathy for ongoing Bortezomib administration. For our next audience response question, AS has completed 4 cycles of Daratumumab plus VTd, or Bortezomib, thalidomide, and dexamethasone, underwent an autologous stem cell transplant, and 2 consolidative cycles of Daratumumab VTd, achieving a stringent complete response. Although recommended by her healthcare team, she chose to forego maintenance therapy following induction. She presents 2 years later with progressive disease and requires further therapy. Which of the following is the most appropriate therapy for AS at this time? The correct answer we were looking for here is C, Carfilzomib, Lenalidomide, and dexamethasone. For A, although this is a reasonable triplet therapy, VMP, as I mentioned previously, is largely fallen out of favor in the United States. It's still used in Europe. However, we have numerous additional novel agents that have come out in the last 5 to 10 years. We're optimizing combination therapies, and we have numerous options that are available to us that are significantly preferred over VMP. Elotuzumab-based combination therapies may be reasonable in the relapse setting. However, elotuzumab is only currently recommended in combination with lenalidomide and dexamethasone as per the ELOQUENT-2 study, pomalidomide and dexamethasone as per the ELOQUENT-3 study, or it can actually be given in combination with bortezomib and dexamethasone as well. The last option here, bendamustine, bortezomib, and dexamethasone, although bendamustine does have some activity in multiple myeloma, it's largely reserved for the heavily relapsed setting in the context of patients who have become relapsed and refractory to multiple agents that we have available. Here we come to the alphabet soup portion of the treatment of multiple myeloma. In the relapsed and refractory setting of multiple myeloma, we thankfully have numerous novel agents in the past several years. We have a lot of different optimized combination therapies. However, we still have the question of proper sequencing of these therapies, which combinations may be preferred over others, because as I mentioned previously, we don't have a lot of comparators between these combination triplet therapies, looking at efficacy and toxicity endpoints. So we have the individual studies that got them recommended. However, we don't really know necessarily if there's one that we should prefer over the other. Largely in the context of relapsed and refractory disease, toxicity profile, prior agents they've been exposed to, financial burden, patient convenience, these sorts of things are going to play significantly into the treatment selection. For patients that have relapsed, for their initial relapse, if the regimen that they initially received, they received it and they went at least 6 months after without progression of disease, you can actually re-challenge with that same regimen again. So if a patient received VRd, for instance, and they didn't proceed on to lenalidomide maintenance, they didn't get a transplant, maybe they were just observed, maybe they had sort of an indolent disease process and they come back a couple of years later with biochemical progression, you can actually re-challenge with VRd as well. Looking at the preferred regimens that we have here, we do have several category 1 recommendations. We have our primary triplet therapy with KRd, Carfilzomib, Lenalidomide, and Dexamethasone. And now we're looking at numerous combinations of Daratumumab. So we have Daratumumab with Bortezomib and Dexamethasone, Lenalidomide and Dexamethasone. Carfilzomib and Dexamethasone is actually a relatively recent FDA approval based on the CANDOR study. And then we have Ixazomib, which is actually a second-generation CD38 targeting monoclonal antibody that can be given only right now in combination with pomalidomide and dexamethasone. And then some additional options that you can see over on the right side. Continuing to look at the numerous options that we have available for relapsed and refractory multiple myeloma, there are just a couple of things that I'd like to point out. One is that we do have Carfilzomib in combination with dexamethasone, which can be given either twice or once weekly. The stronger recommendation is for twice weekly, but we're seeing particularly in the last year or so, more studies are coming out that are using once weekly dosing of Carfilzomib, and there's a lot of extrapolation that's occurred in the last year or so, particularly with the pandemic, to limit patients having to come in twice a week just for their intravenous infusion, when we've seen that once weekly dosing is at least non-inferior to twice weekly dosing, depending on the combination therapy that's utilized. We also have a couple of new approvals. So selinexor, last year we talked about the original approval, which was in combination with dexamethasone in the heavily relapsed setting. Selinexor in that study was given twice weekly, was very toxic. But now we had a very recent FDA approval, which is selinexor once weekly in combination with bortezomib and dexamethasone as per the Boston study. The toxicity profile for this, the response rates were significantly better than the STORM trial, although it was utilized in an earlier relapse compared to STORM. Belantamab mafodotin is our antibody drug conjugate targeting BCMA that we'll talk about momentarily, has good response rates but a very unique toxicity profile. Bendamustine, I had mentioned, can be used typically in the heavily relapsed setting. Looking over on the right side, we do always have the option of giving DCEP or VDT-PACE, which again are our infusional therapies. We're thinking about 96-hour continuous infusion of conventional chemotherapy. So not only are they very toxic, but they can be very effective. Typically, these are utilized as a bridge to an additional therapy. These may be used as a bridge to an autologous stem cell transplant, or a patient may be admitted for disease-associated sequelae. They need this as a bridge to kind of decrease their plasma cell burden before they then can transition to one of these more appropriate outpatient-based regimens looking longitudinally. On the bottom right, we see a couple of other kind of novel combination therapies. Again, selinexor dex was the original approval. It can also be given in combination with daratumumab or pomalidomide. And then venetoclax is our BCL2 inhibitor. Venetoclax is actually being studied in numerous contexts. Primary study we're looking at is the Bellini trial. We've seen significant benefit for venetoclax in patients who have translocation 11-14 in particular. So originally when they looked at venetoclax in myeloma patients, they looked at all comers, found increased toxicity profiles, pretty poor response rates, except for the subgroup of patients that had this translocation because it causes upregulation of BCL2, making it apt to respond to a BCL2 inhibitor. In our next audience response question, again, we have AS, who calls clinic and requests to speak with you regarding carfilzomib, lenalidomide, and dexamethasone. She's inquiring about what supportive care medications she should start with therapy. Her performance status is ECOG 0 with no significant comorbidities or risk factors. In addition to venous thromboembolism prophylaxis, which of the following do you recommend she start with the initiation of KRd? The correct answer we were looking for here is A, acyclovir. All patients who are receiving a proteasome inhibitor, being Bortezomib, Carfilzomib, or Ixazomib, should receive prophylaxis for varicella-zoster virus and herpes simplex virus. This also includes a recommendation for VZV prophylaxis in patients who are receiving Daratumumab, Isatuximab, or Elotuzumab. B, although valganciclovir does cover HSV and VZV, this would be a little bit overkill and should typically be reserved for prophylaxis and treatment of cytomegalovirus. Sulfamethoxazole and trimethoprim, although technically is not necessarily wrong, PCP prophylaxis is generally reserved for the frontline induction therapy, and even in that context is not necessarily a standard of care. Rather, it's suggested as a potential consideration to consider PCP prophylaxis in primary induction therapies, and you won't see it very frequently, particularly in the relapse setting, unless we're looking at the peri-transplant period, in which those patients should be receiving PCP prophylaxis, or in someone who may be profoundly lymphopenic for a long duration. C, valacyclovir would be completely reasonable for VZV and HSV prophylaxis, as would acyclovir. Posaconazole is not going to be necessarily required for these patients. It's something that we're thinking more about in our leukemic patients who are profoundly neutropenic for prolonged periods of time. And then D is clearly incorrect because we're looking at that HSV and VZV prophylaxis for all patients receiving a proteasome inhibitor. The first study we'll briefly look at in the relapse setting is that of KRd. Here we're looking at the Aspire trial, which looked at lenalidomide and dexamethasone plus or minus Carfilzomib. One thing to point out here is Carfilzomib, yes, we have the first week dosing of 20 milligram per meter squared, but then they continue to 27 milligram per meter squared on a twice weekly basis. It should be known that largely in clinical practice, we're looking more frequently at a dose of 36 milligram per meter squared twice weekly, or up to a maximum of 56 milligram per meter squared twice weekly. So if we're thinking twice weekly dosing, typically what you'll see is either 36 or 56 milligram per meter squared. For these patients, we can see obviously there was an improvement in overall response rate with the addition of Carfilzomib to lenalidomide and dexamethasone, as you may expect. Progression-free survival and overall survival were also significantly improved with the addition of Carfilzomib. The adverse effect profile, one thing to point out, obviously we know Carfilzomib, we don't tend to think about being associated with peripheral neuropathy, and there was no difference between lenalidomide and dex versus lenalidomide, dex, and Carfilzomib in rates of neuropathy, but we do see the cardiovascular toxicity profile of Carfilzomib. So we have dyspnea, cardiac failure, hypertension. We should always be thinking about the cardiovascular toxicity profile and potential of Carfilzomib. The original approval of Carfilzomib recommended significant amounts of IV fluid being administered. In clinical practice, depending on the institution, some institutions will actually limit the amount of IV fluid being administered with Carfilzomib to just the first 2 doses of Carfilzomib. As you can imagine, some of the heart failure associated symptoms of Carfilzomib may be partially due to some of those large amounts of fluids that we're giving to patients on their Carfilzomib administration days. The original basis of once-weekly dosing of Carfilzomib is based on the Champion trial, which led to then the Arrow trial here. This is a large group of patients with relapsed and refractory myeloma who are randomized to either once-weekly dosing, looking at 20/27 milligram per meter squared. Again, recall that I just mentioned 27 milligrams per meter squared is typically lower than you would expect in clinical practice for twice-weekly dosing these days. And then once-weekly dosing of Carfilzomib, 20/70 milligram per meter squared. So again, they're receiving 20 milligram per meter squared on day 1 and 70 milligrams per meter squared thereafter. Looking at the overall response rate, they actually found that it was significantly higher with higher depth of response, patients attaining at least a CR with once-weekly dosing, and progression-free survival was prolonged by about 4 months or so, and this was statistically significant. Notable things is that, yes, they had an increased grade 3 to 4 toxicity profile with once-weekly dosing, but they didn't actually see an increase in cardiovascular toxicity, which was the significant worry of folks looking at this once-weekly dosing at the higher dose of 70 milligram per meter squared. Common adverse effects that you may expect would be myelosuppression and pneumonia / upper respiratory infections. So this once-weekly dosing is something that's being incorporated in many or most Carfilzomib-based studies going forward. A lot of folks, like I mentioned during the pandemic, have extrapolated to different Carfilzomib-based therapies to try to administer once-weekly dosing in lieu of twice-weekly doses for patients having to come in and out of clinic. The next couple of slides will look at Daratumumab, particularly in the context of relapsed and refractory disease, which is where it really got its original place and original FDA approval in 2015 based on this study, the Sirius study. This was a relatively small trial looking at patients in the heavily relapsed setting after at least 3 prior lines of therapy. The schedule was the original FDA-approved schedule that you'll note for most regimens, and although the overall response rate of 29% at face value looks to be relatively modest, we have to keep in mind that this was, again, a heavily relapsed patient population. So that progression-free survival of 3.7 months, again, at face value, not terribly impressive, but in this heavily relapsed patient population, it certainly is. The adverse effect profile is, as you would expect, fatigue, myelosuppression, and infusion-related reactions, owing to the fact that we do need to give it over prolonged infusion for the first 2 doses. And then based on the experience with The Ohio State University, we can give it over 90 minutes as a rapid infusion thereafter. And then we actually do have the recently FDA-approved subcutaneous formulation of Daratumumab, like I previously mentioned, which can be substituted for any intravenous Daratumumab-based regimen as per the NCCN guidelines. The rates of infusion or systemic related reactions to the subcutaneous formulation are much lower than they are with the intravenous administration of Daratumumab. The next 2 studies for Daratumumab in the relapse setting are the Pollux study in combination with Lenalidomide and Dexamethasone, and Castor in combination with Bortezomib and Dexamethasone. Looking at the Pollux study with Lenalidomide, we have our standard FDA-approved schedule of Daratumumab, and you can see the overall response rate, as you would expect, is significantly improved to 93% compared to 76.4% with Lenalidomide and Dexamethasone. We're seeing deeper responses with more patients attaining at least a CR, and 30% of patients actually attained MRD negativity compared to just 5% in the Lenalidomide and Dexamethasone group. Progression-free survival was significantly improved to 44.5 compared to 17.5 months with the addition of Daratumumab. When we look at Daratumumab being added to Bortezomib and Dexamethasone as per the Castor study, the schedule for Daratumumab is a little bit different, and that's why I had it listed out here. So the FDA-approved dosing schedule for this combination specifically is different from all other Daratumumab-containing regimens. It's a little bit difficult to coordinate with order sets, so a lot of times people will actually just utilize the standard Daratumumab scheduling, which is noted on the left side under Pollux. Similarly, prolonged overall response or prolonged progression-free survival, looking at 17 months compared to 7 months. The overall response rate and depth of responses were significantly improved with the addition of Daratumumab. And again, MRD negativity significantly improved, albeit not quite as high as that seen with Lenalidomide and Dexamethasone in the Pollux study. The last study that we don't have included in the slides here is the Candor trial. The Candor trial actually looked at the combination of Daratumumab with Carfilzomib and Dexamethasone. Along the same lines, at the same time Candor was happening, there was an analogous study, the Aculeus study. So Candor looked at twice-weekly dosing of Carfilzomib with Daratumumab. The Aculeus study looked at once-weekly dosing of Carfilzomib. And based on both of these studies in combination, we had FDA approval of the combination of Daratumumab and Carfilzomib and Dexamethasone in the relapsed and refractory setting. The FDA-approved dosing of Carfilzomib in that context can either be once-weekly dosing, up to that 70 milligram per meter squared dose that we saw previously, or twice-weekly dosing, again, up to 56 milligram per meter squared, as you may expect. Our second-generation CD38 targeting monoclonal antibody is Ixazomib. So Ixazomib was FDA approved based on the ICARIA-MM study, which was a phase 3 randomized study looking at 307 patients with relapsed myeloma after at least 2 prior lines of therapy, and they were randomized to either pomalidomide and dexamethasone plus or minus Ixazomib. You can see the dosing schedule of Ixazomib listed there. As we may expect, the addition of CD38 targeting monoclonal antibody improved the progression-free survival. The toxicity profile was unsurprising for a CD38 targeting monoclonal antibody. We had infusion reactions, so there is a pre-medication schema noted on the right side there, extended initial infusions for the first couple of doses, and higher rates of upper respiratory infections and GI toxicity. When we think about Ixazomib itself, the FDA approval was in response to the ICARIA study. Mechanism of action, we know CD38 targeting monoclonal antibody is going to have that antibody-dependent, complement-dependent cytotoxicity. It was FDA approved for relapsed myeloma after at least 2 prior lines, but that must include lenalidomide and a proteasome inhibitor. And as of right now, we do have those extended infusions, but likely we're going to get more experience, presumably with rapid infusion protocol and then subcutaneous administration in the coming years. With regard to the place in therapy for Ixazomib, Patients were excluded from this study if they had received prior CD38 targeting monoclonal antibodies, so Daratumumab, or pomalidomide. So we really don't know the context or where to sequence this drug. Very likely in the next several months or a couple of years, we're going to see isatuximab used in different combination therapies, different lines of therapy, where we're going to start to see it really work its way into the treatment paradigm itself. Elotuzumab is our SLAMF7 targeting monoclonal antibody, and the two most notable studies that we have right now for this are ELOQUENT-2, looking at it in combination with lenalidomide and dexamethasone, and ELOQUENT-3 in combination with pomalidomide and dexamethasone. For the ELOQUENT-2 study, this is a very large phase 3 study of just about 650 patients after 1 to 3 prior lines of therapy. This dosing schedule is the original dosing schedule that you will see for elotuzumab. And the adverse effect profile is pretty much what you would expect. You expect some myelosuppression. There is the risk of infusion reactions, so we do have prolonged initial infusion and a pre-medication schema that is required for it. When we look at the responses, the addition of elotuzumab increased the overall response rate significantly, and progression-free survival was prolonged by just about 5 months. When we combine elotuzumab with pomalidomide, as per the ELOQUENT-3 study, again, we're looking at a little bit of a dosing schedule modification for elotuzumab, kind of like when we think back to the CASTOR and Bortezomib study. But these patients actually got the original lead-in dosing for 2 cycles again, but then they went to once monthly dosing at 20 milligram per kilogram every 4 weeks thereafter, as opposed to every 2 weeks, as per the ELOQUENT-2 with lenalidomide and dexamethasone. These patients had to have received prior lenalidomide and a proteasome inhibitor. And again, you see the overall response rates, 53% compared to 26%. And progression-free survival, again, was prolonged by about 5.6 months for these patients with the addition of elotuzumab. Ixazomib is our oral proteasome inhibitor, which can be used in numerous combinations, but the most common combination of which would be in combination with lenalidomide and dexamethasone, which we've seen for the Tourmaline study in the front line, and now we're seeing in the relapsed and refractory setting. So the obvious benefit to this is all oral regimen, right? So with the addition of Ixazomib to lenalidomide, we saw an increase in the overall response rate. We did see deepening of responses with nearly 12% of patients having a CR, and then progression-free survival was prolonged by about 6 months. When we think about the toxicity profile of Ixazomib, since it is oral, we do see more GI toxicities compared to the other proteasome inhibitors. It can certainly cause rash, like many of our oral anti-neoplastics can. And then when we're thinking about myelosuppression, actually thrombocytopenia is one that sticks out for Ixazomib a little bit more than the other lineages. The next available agent that we have is panobinostat, which is our only histone deacetylase inhibitor approved for multiple myeloma. This was based on the Panorama trial, which looked at panobinostat in combination with Bortezomib and dexamethasone. You can see that it clearly improved overall response rate, depth of response with CR, as well as progression-free survival, with no improvement, statistically significantly speaking, in overall survival. I would like to point out the toxicity profile of panobinostat. This is given typically 3 times a week for 2 weeks in a row with a week off. But I want to point out the GI toxicity in particular. This is an oral anti-neoplastic that does cause a fair amount of nausea and diarrhea. That diarrhea can cause significant electrolyte abnormalities, which also compounds itself into QTc prolongation. So oftentimes third-party payers will actually require an EKG documenting a QTc less than 450 milliseconds to allow the patient to start therapy. To briefly touch on selinexor and the STORM study, because we did talk about this again last year. It was brand new last year, so this led to the FDA approval initially for selinexor in combination with dexamethasone. The original dosing schedule, you can see, was 80 milligrams twice a week with no off week of selinexor, and these were patients who were deemed to be quote-unquote penta-refractory, previously treated with Bortezomib, Carfilzomib, lenalidomide, pomalidomide, and Daratumumab. So we're talking about a very, very heavily relapsed and refractory patient population. Response rate, similar to what we looked at for that original Sirius study of Daratumumab, 26%. Progression-free survival was only about 3 months or so. The toxicity profile for selinexor can be difficult to manage. We see profound myelosuppression of all 3 lineages. They can have significant GI toxicity. The nausea is severe enough that you should be pre-medicating with a 5-HT3 antagonist, and you may consider addition of additional agents such as olanzapine, low-dose olanzapine, to help out with that. So the toxicity profile can be very difficult for selinexor to manage. I mentioned some of these things previously, but this is a novel mechanism of action. So this is our first exportin-1 or nuclear export inhibitor. Basically, it leads to accumulation of tumor suppressor proteins and subsequently apoptosis. The original dosing schedule there is 80 milligrams twice weekly, and we do need to have anti-nausea and emetogenic regimen up front. You can see the dose adjustments that are listed there. It is a major 3A4 substrate, so we do need to keep that in mind. Importantly, we did just have a recent FDA approval of selinexor being given in combination with bortezomib and dexamethasone. This is what we kind of expected. It's working its way farther up in lines of therapy. This was approved after at least one prior line. Now, the dosing of selinexor for this study was actually 100 milligrams once a week rather than twice a week. And what we saw was that the tolerability was actually significantly better. It does still have a lot of the myelosuppression. It does have fatigue. It does have nausea and GI toxicity, but those were better tolerated than the twice weekly dosing schedule of selinexor that may owe in part to the patient population that was utilized. But now selinexor is starting to work its way into different combination therapies, and we'll likely see increased utilization of this drug going forward. The last drug that we'll talk about is Daratumumab VTd, which was a very recent, exciting FDA approval. This is our first antibody drug conjugate in multiple myeloma, and it's targeting BCMA, or B-cell maturation antigen. This was based on the DREAM2 study, which looked at monotherapy of Daratumumab VTd. It looked at it in two cohorts, 2.5 milligram per kilogram, which was ultimately the FDA-approved dose, and 3.4 milligram per kilogram. The overall responses between those two dosing cohorts were similar, 31 and 34%, with similar rates of at least VGPR. Notably, the unique toxicity profile of Daratumumab VTd includes, yes, myelosuppression, but more importantly, ocular toxicity, with keratopathy occurring in 27% and 21% of patients in the 2.5 and 3.4 milligram per kilogram groups, respectively. As I mentioned, this is our first antibody-drug conjugate in myeloma. So what we have is a BCMA-targeted monoclonal antibody that's conjugated to monomethyl auristatin F, or MMAF, which is an anti-microtubule agent. So this payload is dropped off to the myeloma cells by targeting BCMA. It's internalized and then has its microtubule inhibition effect. The FDA-approved dose, as I mentioned, is 2.5 milligram per kilogram. This is given over 30 minutes. Although there is a small rate of infusion reactions, there is no standard pre-medication for the initial dose. There's one dose reduction level from 2.5 milligram per kilogram to 1.9. Below that, it's actually recommended for discontinuation. Like I mentioned, the ocular toxicity is very unique, and this is owing to the MMAF targeted payload. This can cause significant, not just keratopathy, but it can cause blurred vision, actually vision loss. It can cause corneal ulcers in very rare cases. So patients actually need to use preservative-free lubricant eye drops 4 times a day, every single day throughout therapy. To enforce this, there is a REMS, or Risk Evaluation and Mitigation Strategy program, that has an online portal that the patient needs to register with, the provider needs to register with, and the healthcare facility does. In order to enforce that patients are being monitored for ocular toxicity, they need to have a screening with an ophthalmologist before every single dose. Before the first dose, it needs to occur within 3 weeks prior to the dose. All subsequent doses, it cannot be within 7 days after administration of the drug, but it must be within a 2-week window leading up to the next administration, which makes sense given a 21-day cycle. These ophthalmologists will look at the Snellen visual acuity test to see their visual acuity, and they'll also take a look through a slit lamp at their corneas. Based on this, they grade them per the common terminology criteria for adverse events, return that information to the oncologist, who submits this information to the REMS portal, and through this, we're able to decide, can we give the dose at full dose for this cycle? Do we need to adjust it? Do we need to hold it and then reassess with an ophthalmologist? All of this needs to be documented in the online portal. It's a very extensive process, but it's necessary due to this potentially severe unique toxicity of ocular toxicity with this drug. To summarize the management of relapsed and refractory myeloma, again, we have multiple combination therapies. We have, thankfully, novel drugs that are being FDA approved with relative frequency. We do expect a new CAR T-cell to be approved in the next few months. So we have a lot of different options. The question becomes sequencing. How do we decide which combination therapy to use? A lot of this depends, like I mentioned, on the toxicity profile, financial burdens, comorbidities that patients may have, patient preference, and convenience. If a patient relapses after at least 6 months following their original induction therapy, you can actually re-challenge with that same induction therapy, but we do expect that the depth and duration of responses with each occurrence and recurrence will reduce in time. AS is now cycle 2 of salvage therapy with KRd. She received a bisphosphonate during her original induction therapy, and now her oncologist would like to resume bone-modifying therapy. Her creatinine clearance is 85 milliliters a minute. Which of the following do you recommend initiating at this time? The correct answer is B, pamidronate 90 milligrams intravenously over 4 hours. A is incorrect because although zoledronic acid 4 milligrams is the correct dose, this should be given over an intravenous IV piggyback over at least 15 minutes. Typically, providers will give it over 30 minutes, sometimes up to 45 minutes. C is incorrect because denosumab is administered subcutaneously. 120 milligrams is the appropriate dose for prevention of skeletal-related events in multiple myeloma and solid tumors with bone effects. D is incorrect because denosumab 60 milligrams subcutaneously is reserved for the brand name Prolia, which is used for osteoporosis, outside of the context of prevention of skeletal-related events related to multiple myeloma. We mentioned previously when looking at the myeloma-defining events that the B in CRAB is actually bone involvement or lytic lesions that can happen related to the increase in osteoclastic activity that's caused by these terminally differentiated plasma cells. So we know that osteolytic lesions can develop in many patients, either in the front line or with relapse. Osteopenia is also something that tends to come along with these patients as they have weakening of their bone as well. So we have these drugs, bisphosphonates, zoledronic acid, and pamidronate, or a rank ligand inhibitor such as denosumab, that can not just reduce skeletal-related events and fractures, but they can decrease pain and significantly improve patients' quality of life going forward. The first class of drugs that we have for prevention of skeletal-related events in myeloma are the bisphosphonates. These are indicated for patients with lytic destruction of their bone or without lytic destruction of their bone with osteopenia, which truthfully will encompass most myeloma patients. It's not indicated for patients with monoclonal gammopathy of undetermined significance, smoldering myeloma, or those with a solitary plasmacytoma for which you're likely going to radiate the lesion. It's recommended based on the guidelines to continue treatment for 2 years, and thereafter it's based on the provider preference if you'd like to continue. Patients who relapse after having finished their bisphosphonate therapy, it's recommended to actually restart bisphosphonate therapy for bone modification. Typical dosing and schedule you can see on the right side here for zoledronic acid and pamidronate. The main thing I'll point out is that you dose adjust these for prevention of skeletal-related events, but when we get to it with hypercalcemia, you actually do not dose adjust based on renal dysfunction. As we know, the bisphosphonates can cause nephrotoxicity. It's very important to monitor the renal function prior to each dose. And we know this rare but very severe toxicity of osteonecrosis of the jaw can occur with bisphosphonates. Patients should therefore have comprehensive dental exam prior to starting therapy. They should have clearance from the dentist provided to the oncologist. Any active oral infections or invasive dental procedures should be taken care of before starting therapy. Thereafter, it's really important to have good communication between the dental provider and the oncologist with regard to any potential pauses in bisphosphonate therapy for any dental procedures. Patients receiving bisphosphonates should receive daily calcium supplement as long as they're not hypercalcemic related to their disease, and vitamin D supplementation. The next drug that we have is denosumab, our rank ligand inhibitor. Rank ligand is actually secreted by osteoblasts, which we know build up bone, to then cause maturation of osteoclastic precursors and activation of osteoclasts. So inhibiting this process can inhibit, ultimately, osteoclastic function and reduce lytic lesions. This can be used for prevention of skeletal-related events in patients with myeloma or those with bone metastases from solid tumors. The same monitoring with the absence of renal function, because we know this monoclonal antibody is not going to be cleared renally, nor is it really nephrotoxic, is that we do still need to screen for osteonecrosis of the jaw and be very mindful of that. In a comparator trial between denosumab and zoledronic acid, there were similar rates of about 3% of osteonecrosis of the jaw between denosumab and zoledronic acid. Patients receiving denosumab in the clinical trials received calcium and vitamin D supplementation, as you may expect. In our next audience response question, we have JN, who's unfortunately progressed to active multiple myeloma and presents to the urgent care center with lethargy and constipation. His labs are notable for a calcium of 10.9, serum creatinine of 2.6, and an albumin of 2.5. In addition to aggressive hydration, which of the following interventions would be the most appropriate for JM? The answer we're looking for is D, zoledronic acid 4 milligrams with calcitonin subcutaneously. A is incorrect because although calcitonin can be used for symptomatic hypercalcemia, the intranasal dosage administration is actually ineffective for this indication. Furosemide is incorrect because, again, although we can use furosemide for forced diuresis to allow us to give more IV fluid to patients, this is not your primary therapy. C is incorrect because, as I just mentioned, zoledronic acid should be dose adjusted for renal dysfunction and the prevention of skeletal-related events, but not for the treatment of hypercalcemia. Here we have some of the more common causes of hypercalcemia malignancy. Clearly, you see the most common would be the humoral hypercalcemia in your squamous cell cancers, ovarian, endometrial, and breast. The local osteolytic hypercalcemia related to osteoclastic upregulation is what we're thinking about for myeloma patients. For lymphoma, you can have this increase in vitamin D activity. So this is one that's going to be susceptible, in addition to our primary therapies, to steroids. For the diagnosis of hypercalcemia, we want to first correct the calcium for hypoalbuminemia, which we do actually expect in many of our myeloma patients. In addition to that, you can get a better picture of their actual calcium status by measuring an ionized calcium too. We have levels of hypercalcemia here. These are likely going to differ by institution, but more important is the clinical presentation. Patients may come in with newly diagnosed myeloma and hypercalcemia, lethargic, altered mental status. They may be having severe nausea and constipation. These are things that may actually move you in the direction of thinking about hypercalcemia while you're waiting for those labs to come back. The primary management for hypercalcemia when we have someone presenting to an urgent care or emergency department is going to be IV fluids at a high rate, normal saline, up to 150 to 200 cc's an hour. We want to try to get the patient to euvolemia, likely even probably far beyond that, in which case we may want to use loop diuretics for forced diuresis to be able to keep diuresing them. Primary therapy is clearly going to be our IV bisphosphonates, potentially denosumab or rank ligand inhibitor, and our secondary therapies such as calcitonin and glucocorticoids. Important things to keep in mind when we're looking at bisphosphonates or zoledronic acid, pamidronate for the treatment of hypercalcemia is that the response is not going to be immediate. It can take 48 hours or more to have a response. The nadir can be anywhere between 4 and 7 days. Typically, we think about its peak effect being about 7 days, and that's when we may consider redosing the bisphosphonate in a patient that's not responded appropriately. You can see the dosing there for the agents that we use. And again, like I mentioned previously, renal dose adjustments are actually not recommended in the treatment of hypercalcemia, particularly for patients with a serum creatinine up to 4.5. The adverse effects are similar to what you may expect for skeletal-related events. This includes a flu-like malaise, fevers, arthralgias, nephrotoxicity, and we still do have that potential for osteonecrosis of the jaw. The flu-like malaise and fevers primarily are really just treated with acetaminophen that we can do for treatment after the fact, and sometimes if we need to redose, we can do it preventatively and prophylactically as well. Denosumab, our rank ligand inhibitor for hypercalcemia, has a similar response, typically within 48 hours to 96 hours, with a peak effect that's a little bit delayed compared to the bisphosphonates. The actual approved dosing for it is on a weekly basis and then monthly thereafter, but typically when you see it, it'll be in the context of either renal impairment or refractory to bisphosphonates. So you're going to give it once and then probably monitor the response before giving it thereafter. Toxicity profile, similarly, you can see severe hypocalcemia and hypophosphatemia, particularly in patients that have severe renal impairment. So this is something to keep a close eye on for those patients. The next agent we have available for hypercalcemia is calcitonin. This one, like I mentioned, the nasal administration is not going to be effective. We're looking at a dose of typically 4 units per kilogram every 12 hours. It should be given IM or subcutaneously. Its onset is much quicker. This is when we have a patient who's symptomatic. We can't wait for that 2 to 4 days for a bisphosphonate or denosumab to kick in. We want calcitonin to start working within a few hours. It does have the potential for tachyphylaxis, meaning that we can't be giving it for several days in a row because its effects are going to diminish over time. Typically, if I'm going to recommend it, I'll recommend it being ordered every 12 hours for the first 2 days, and then we can reassess after those 2 days. Lastly, for our other therapies that we have available, Generally, we can use steroids for some of these lymphomas that have elevated levels of vitamin D. We clearly can give pulse steroids, typically pulse dexamethasone for 4 days or so for multiple myeloma patients to treat the disease-causing source of hypercalcemia. Calcimimetic can be used for parathyroid carcinoma or primary secondary hyperparathyroidism. And then in severe hypercalcemia with renal insufficiency and you can't hydrate these patients, dialysis is your last option. For our next audience response question, upon initiating KRd for her relapsed multiple myeloma, AS was deemed to be at high risk of venous thromboembolism, VTE, due to her Lenalidomide-based therapy, obesity, and a prior history of VTE before her myeloma diagnosis. She's not interested in injections and requests an oral medication for VTE prophylaxis. Which of the following is the most appropriate for AS? The correct answer is A, apixaban 2.5 milligrams twice daily. B would be incorrect because although aspirin may be appropriate for a low-risk patient, she was deemed to be high risk for VTE as per both the SAVED and IMPEDE VTE scoring systems. C is incorrect because 20 milligrams of rivaroxaban would be a treatment dose. We may use 10 milligrams of rivaroxaban for prophylaxis of VTE in a medical oncology patient as per the Corona criteria. However, the SAVED and IMPEDE criteria and recommendations for myeloma patients do not currently suggest rivaroxaban as a prophylactic agent. D, warfarin may be an appropriate option for a high-risk patient. However, if used, it should be used to an INR goal of 2 to 3. This slide is more for your reference, but this includes some of the VTE risk factors in medical oncology patients, including those patient-associated risk factors, treatment-related risk factors, and those deemed to be modifiable risk factors. Although we know patients with malignancies are at higher risk of VTE in general, we must take into consideration risk stratification scoring and how to best identify patients who would benefit from outpatient VTE prophylaxis. For those patients who are medical oncology non-myeloma patients, you should look at the Corona risk score, which will be on the next slide. You may consider oral anticoagulation for these patients for up to 6 months with either apixaban or rivaroxaban. For patients with multiple myeloma, 2 new externally validated risk assessment tools, including the SAVED and IMPEDE stratification tools, will be discussed momentarily. Major cancer surgery patients should receive perioperative prophylaxis for 7 to 10 days post-operatively, and you may consider up to 4 weeks of prophylaxis in high-risk abdominal and pelvic surgeries. For all other medical oncology outpatients, no routine VTE prophylaxis is recommended outside of a clinical trial. For your reference, as on the previous slide, the Corona predictive model helps to determine which medical oncology patients may benefit from anticoagulant prophylaxis. The scoring system is on the left, and the recommendations based on the score per the patient is on the bottom right. The SAVED criteria is analogous to the Corona criteria, but this applies to multiple myeloma patients. This is one of the recent externally validated scoring systems that's made its way into the national guidelines. As you can see on the left, we have the risk factors and the points allocated to them, and on the bottom right, the recommendations for myeloma patients receiving immunomodulatory agents and their prophylaxis, including for high-risk enoxaparin, dalteparin, warfarin, or apixaban. For low-risk patients, either no intervention or much more likely, aspirin. The IMPEDE VTE score is the second recent addition to the guidelines as externally validated VTE risk scoring in myeloma patients, in addition to the SAVED criteria. Similarly, on the left side, you can see the risk factors and associated points, and on the right side, based on that final point tally, the recommendations, which are the same recommendations for high and low risk as the SAVED criteria. Following JM's initial presentation, he's incidentally found to have a lower extremity DVT. The medical team is planning his discharge from the hospital and would like to prescribe his therapeutic anticoagulation. Which of the following is the most appropriate option at hospital discharge for JM? He weighs 78 kilograms, serum creatinine of 0.92, and his platelets are 38,000. The correct answer is B, enoxaparin 40 milligrams subcutaneously every 12 hours. This would be a half of a treatment dose, 0.5 milligrams per kilogram every 12 hours, which is recommended as per the guidelines for patients with platelets of 25 to 50,000. For those less than 25,000, it's recommended to hold anticoagulation. A, aspirin would be insufficient for treatment of VTE. C, would be full dose and not adjusted for his thrombocytopenia. And D, although apixaban may be utilized in the context of treatment of DVT, is the dosing used for rivaroxaban. In the treatment of VTE malignancy, a duration of at least 3 months is recommended by the clinical practice guidelines, or as long as a patient has an active malignancy. So those patients still receiving anti-cancer therapy should remain on anticoagulation. It should be noted that the practice guidelines actually now prefer direct oral anticoagulation, as long as the patient does not have a gastric or gastroesophageal lesion, in which case a low molecular weight heparin is still preferred. In patients who do not have gastric or gastroesophageal lesions, these are the direct oral anticoagulants that are preferred by the clinical practice guidelines. As you can see, apixaban and edoxaban are the only Category 1 recommendations. Rivaroxaban and dabigatran may be utilized if the other agents are not available or otherwise contraindicated. In this table for your reference are the dosing of these agents. For those patients with gastric and gastroesophageal lesions, low molecular weight heparins and fondaparinux or unfractionated heparin are still preferred. Dalteparin is still the only Category 1 recommendation for this context. The dosing is listed in this table for your reference as well. And finally, warfarin remains an option for the treatment of venous thromboembolism, although it may be difficult to administer to a medical oncology patient. Again, some of the dosing information and monitoring is listed on this slide. For the sake of time and for your reference, here's our historical clot trial, which led to the low molecular weight heparin and in particular dalteparin being a preferred agent in the treatment of VTE associated with malignancy. On the right side is the first prospective oral anticoagulant study for edoxaban, but I'll also bring your attention to the ATOM VTE and Caravaggio studies for apixaban, as well as the SELECT-D study for rivaroxaban. Here for your reference is the clinical practice guideline recommendation for management of anticoagulation in the context of chemotherapy-induced thrombocytopenia. This slide includes a brief summary of the prevention and treatment of malignancy-associated VTE. That concludes this presentation. Thank you for participating.